you. Please be seated. We'll go back on the record on case 251-401132, State of Utah versus Sundwall. Ladies and gentlemen of the jury, welcome back. Is the state ready with your next witness?
Yes, thank you, Judge. The state calls Dr. Malcolm Masteller.
Thank you. Please come forward and we'll get you sworn in. Come on up here first near the clerk.
Please raise your right hand. You do solemnly swear the testimony you shall give in the case now before the court will be the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Thank you.
Come on over here and have a seat. Thanks for being here.
You're welcome,
If
Your
you
Honor.
can, if you can keep that mic in front of you at all times, that will help us make a good record and we'll all be able to hear. Counsel.
Thank you. If you could please state your name and spell your last name for the record.
It's Malcolm Masteller, spelled Masteller.
What is your occupation?
Physician.
We'll get to your specialties in a minute, but I want to cover your educational background. Walk us through what that is.
Undergraduate, University of Utah, with a Bachelor's of Science, biology, minor in biochemistry, and a minor in social anthropology.
What did you do after undergrad?
After undergraduate, went to medical school at Rosalind Franklin Medical School in North Chicago. That was followed by residency in Bremerton, Washington, at the Bremerton Naval Hospital.
And what did you do your residency in?
Family medicine.
You said you're currently a physician. Do you have particular specialty?
Family medicine is a specialty and board certified in family medicine.
Help the jury understand, that maybe they already know, but if not, or help me understand what family medicine means generally.
Family medicine encompasses care from newborn until geriatric timeframes. All levels of care. Some will do obstetrics as well. It's fairly broad as to what we can do, what we're credentialed to do, and what. I can go into mine specifically. I see all age groups. I also do urgent care. I will see newborns. The majority of the people I see are between 20 and 100 plus.
So sometimes we hear the term primary care physician. Is that what you might be considered?
Yes.
And you may have already said, I'm sorry, how long have you been a physician?
About 18 years.
And what facility do you work for?
I work for the University of Utah.
How long has that been the case?
12 years.
Where did you work before that?
U.S. Navy?
Anything before that?
No.
You mentioned you're board certified in family medicine.
Yes, I am.
Does your role require ongoing continuing education requirements?
It does. State licensing requires continuing education, as does the board certification. You have to complete so many credit hours of continuing education through conferences, online training, in-person training, etc.
Do you keep current on that?
I do.
All right, I want to talk to you about a patient named Casey Terry. Does that name sound familiar to you?
It does.
Did you know her?
I met her in June of 2020.
In what capacity did you meet her?
I took on being her primary care physician.
You said June of 2020?
Uh-huh.
Do you know about how old she would have been?
34?
Did she have any pre-existing conditions when she started seeing you?
She did.
What were those?
She had a few. Chronic kidney disease. She was seeing a nephrologist. She had diffuse glomerular sclerosis of the kidney, as well as she was born with one kidney. Fibromyalgia, chronic pain condition, endometriosis, von Willebrand's factor deficiency.
Let me stop you there because I don't know what that means.
It's a bleeding disorder. It's a bleeding disorder. They don't have clotting factors that allow them to clot properly. They tend to have bleeding issues, bleeding of the gums. Sometimes women will have heavy cycles.
Okay. Anything else that any other pre-existing conditions that she had when you started seeing her?
Interstitial cystitis,
What does that mean?
painful bladder,
Anything else?
fibromyalgia.
What does that mean?
It's a increase in pain, generalized pain, in the absence of any other medical condition that can explain it. So pain thresholds in these individuals are lower than the average population, and all the autoimmune and other conditions that can cause pain have been ruled out, and they meet the criteria for it.
Okay. Anything else that you haven't mentioned?
Anxiety, depression.
Anything else?
Insomnia. She'd had a problem with weight, had been through a gastric bariatric surgery as well.
Do you remember when that would have been?
I don't remember.
Were
on the
you
surgery.
her primary care physician at that time?
No, it was
So-
long before me.
Okay.
In regards to the bariatric surgery, some vitamin nutrient deficiencies, iron deficiency, also from some bleeding tendencies that she had.
Okay. I did not write down each of those, but I'll try to take them in turn. Well, let me first ask you this. Did she tell you that she had cancer?
No,
You mentioned several things, and I don't know that I'll, like I said, remember all of them. But let's start with her being born with one kidney. Is that something that you were able to independently verify, or were you just taking her word on that being the case?
that was verified on multiple imaging studies. The last being a CT scan in 2023 in an emergency room of the abdomen and pelvis.
I believe you said endometriosis was a pre-existing condition with her. Is that something that you were able to independently verify?
Her gynecologist had retired and records were not available. So that was a subjective health condition.
It sounds like fibromyalgia would also maybe be a subjective condition, just her report of her level of pain.
Yeah, it's a diagnosis of exclusion. So if you've ruled out other causes of pain, a lot of them, then that's the final diagnosis if they meet the criteria. There's a
Okay.
very specific criteria.
And you took her through those criteria, where
Yes,
I guess she at some point had been
she
diagnosed with
had
that?
been diagnosed before. She had already been diagnosed.
Okay.
That was a reported condition.
You said that a nephrologist referred her. What's a nephrologist?
Nephrologist is a kidney doctor.
Okay, we talked about kidney already. And sorry, I'm forgetting the other ones you said. Of the conditions that you listed that she presented with when you began seeing her, what ones were you able to independently verify versus just based on what she's telling you is happening?
So chronic kidney condition, the chronic kidney disease was verified both with laboratory and imaging studies. Endometriosis was not. That is, she had reported surgeries, but it was on the abdomen, which is diagnostic laparoscopies by the gynecologist, both for treatment and diagnosis purposes. Fibromyalgia was verified by clinical criteria after ruling out through blood testing and so forth, multiple other potential causes of joint and muscle pain. Insomnia is a subjective complaint. Depression, anxiety are also often subjective, although her scores on the PHQ-9s and GAD-7. GAD-7 is an anxiety screening test. PHQ gives us quantifiable data on depression scoring. Those were always elevated on both of those.
Okay. What about, I will never be able to pronounce it, the bleeding disorder?
So I was going to get to that. She did complain of bleeding, heavy menstrual cycles, rectal bleeding. Hematology reran the von Willebrand factor prior to her knee surgery, and she did not have it. So that was a subjective medical condition she had when she presented to the clinic.
That you were later able to, it sounds like, rule out?
In 2024, before she had the initial knee surgery on 6/20/24, the meniscal surgery, the von Willebrand factors were run, and she had adequate quantities of those factors to clot, for clotting.
Okay.
So she did not have the condition.
Okay.
It ruled out the condition. So the
Okay.
hematologist said, I do not believe she has von Willebrand factor or a bleeding disorder.
Okay, thank you. You made reference to her knee surgery. Did you say before that she had arthritis?
I did not mention that. That was an oversight. She had moderate to severe osteoarthritis, both knees. Left knee was verified on x-ray, bony arthritis. She can't see soft tissue unless you get an MRI. The right knee was verified, bony arthritis, primarily in the lateral component of the knee joint, as well as extensive cartilage degeneration, I believe tibial plateau and over the tibia and femoral condyles. So what that basically means is the cartilage is breaking down. She had pretty extensive breakdown of cartilage in the knee.
Okay, and we actually have already heard from the surgeon that performed the one knee replacement. Were you involved, obviously you're not the surgeon, but were you involved in kind of helping her make that decision or deciding that was maybe an appropriate path to take?
Yeah, there was a long discussion on both knees.
I'll come back to that in a bit. But fair to say that at least some of the things that Casey came to you complaining of were either entirely subjective or even later ruled out.
Yes.
Would you say that Casey sometimes exaggerated her levels of pain?
Yeah, exaggerated several things. Pain was one of them, yes.
What other things did you find that she may have exaggerated?
So for me and the nephrologist, in June this was started after her knee surgery, her initial knee surgery, there was initial complaints of pain. That kind of disappeared, and then she was complaining of significant weight gain, swelling in the legs. But objectively, there wasn't the degree of weight gain nor the swelling in the legs, both on my exam, the nephrologist's exam, and in the ER note where she had gone in with that complaint.
We've heard from other witnesses that she may have made several trips to the ER, or maybe even frequently went to the ER. Would you have, as her primary care physician, been made aware of ER visits that she had made?
Yes, sometimes. I mean, they will, by her, if we don't always get the notes from the ER, no. We try to keep up on them. Sometimes they're good about sending them, sometimes not. Most of the electronic medical records have gone to a unified system now, so it's much easier. But at the time, not always.
Okay. I want to talk a little bit about her kidney condition. That was one that you're able to verify. She was only born with one kidney. When she came to you, we've heard talk of her having a port. Is that something that she had when she began seeing you, or is that something that you helped her do?
I did not help her. So just to clarify on her kidney condition, she was born with the solitary kidney. She also had a progressive kidney disease, probably from overuse of ibuprofen, anti-inflammatory medications, is what was presumed. There was high-dose anti-inflammatory medications taken for years. But so there was two different, the solitary kidney just gave her one kidney, so kidney function was already overall reduced because you're running off one kidney. But then she also had damage, verified damage to the remaining kidney on a kidney biopsy that I think it was 2020. It's in the notes from the nephrologist.
Okay.
And he had mentioned just that it was presumed that probably due to overuse of ibuprofen.
Okay. That damage to her existing kidney, how might that show up in her? Pain, other symptoms?
No, it's usually painless. We're going to identify it. The labs will show the diminished function and filtration of the kidney. With her, she had a little bit of protein, so we saw on a microscopic level the filters in the kidney were starting to leak a little bit of protein. not large amounts, but enough to pick up on urine testing for protein, and then ultimately it's the biopsy that makes the determination on the kidney disease.
Okay, anything in her day-to-day that she would notice symptomatically from that kidney disease? You said it's typically painless. Any other symptoms?
No, not until it's advanced, until you start to have electrolyte abnormalities and other problems from more advanced than hers.
Okay. Let's talk about her port. Did she have that when she began seeing you?
She did. The kidney doctor had put it in to help her stay hydrated as a protective measure on her kidney.
What is a port?
It's a central line. It's basically a line that's placed through a vein, in her case a vein, probably the subclavian vein. I don't remember which one she had, but I believe, which goes into the heart. But it allows you to receive IV fluids, medication infusions. It allows to draw blood, so that we don't always have to do it through a peripheral placement of an IV. So you're not sticking somebody all the time, trying to find IV sites, and after time, if you're utilizing those a lot, you lose the ability to gain access. So basically what I'm saying, it prevents us from having to poke her every time she comes in, put an IV in, take it out, put another one in.
Okay.
If
so
somebody's obtaining frequent fluids, medications, infusions, or needs frequent blood draws.
Okay. So saves wear and tear on finding other veins.
Yeah, people, you'll see them bruised up all over the place after they've been, and it just saves that. It's an easy access to her vascular system.
And you said her kidney doctor had placed that
Uh-huh.
in her. Where on her body was that located?
I don't remember side laterality. It would have been up on the upper chest.
And I guess, what does that look like physically? Can you immediately tell if somebody has one?
Yeah, you'll see a little bump. It's located under the skin, but they're readily identifiable when you look at the chest wall if you're medically trained.
And do you know, you mentioned a number of things that ports may be used for. Do you know what she primarily was using her port for?
Self-administration of IV fluids, normal saline,
What was that saline needed in her for?
hydration. There was also some thoughts that she may have something called postural orthostatic tachycardic syndrome. She had appointments with cardiology, and they were going to see her. This was later in 2024. She had upcoming appointments with them when she had passed. So they were the workup for this postural orthostatic, and with them as well. This is what we call a dysautonomia, where the autonomic nervous system does not control and regulate heart rate, blood pressure, etc. very well, and her heart rate was always just a little elevated.
Okay, forgive me, I will not be able to remember nor pronounce a lot of the terms that you're using. So this condition that it was maybe suspected that she might have, and you were working on maybe confirming that. What is that?
So again, it's, I'm trying to say it in layman terms. The autonomic nervous system doesn't work. So positional changes, people have a harder time with regulation of heart rate, blood pressure, and so forth, and they frequently will pass out or or feel very lightheaded. With her, it was more lightheadedness and a mild elevation of her heart rate that would accelerate if she stood up.
Is this something that you were, it sounds like there were maybe tests planned to confirm or diagnose her with this, but at the stage she was at, is this something that you're relying on just her subjective complaints about how she's feeling?
In part, yeah. Well, there's verifiable with the heart rate.
Okay.
Yeah, postural orthostatic tachycardic syndrome means, what all those words mean is that with positional changes, you're going to see an elevation of a heart rate. For example, from supine or lying down to sitting to standing, you're going to see the heart rate elevate when inappropriately elevate.
Okay, and that is something that you could independently verify?
Yeah, her heart rate was high, and she would. Now, just dehydration can also do that. So if someone comes in dehydrated, they're also going to show the same signs. So, but yes, and consistently her heart rate was a little bit elevated. And the point with that is it also requires IV fluids Or,
Okay.
I take that back, it does not require, it requires increased fluids.
Increased fluids, okay. You mentioned that she was using saline through her port for hydration.
Yes.
Is that typical for someone with her kidney issues?
No. I mean, we don't put ports in, there are potential complications with ports. Infection is probably the most prominent and probable, although it's relatively rare. So no, we don't, but her nephrologist had opted to, because she had fibrosis on the liver and she was at, I think she was chronic kidney disease stage 3B, or 3A, sorry. And it goes 1, 2, 3, 4, and 5. 5 is end-stage renal disease. So she was at 3A. He was doing, his thought was, I need to protect this kidney. She also had some chronic nausea, which is a subjective complaint. She was on chronic nausea medication, had a hard time staying hydrated.
Okay. When someone has a port and they're using saline, is that something that has to be prescribed? Can they get that over the counter? How was Casey getting saline?
It's prescribed.
Were you prescribing that?
I don't remember, honestly. I may have prescribed it once. Nephrology had prescribed it for quite a long time, and I very well could have prescribed it.
I want to talk about other prescriptions. When she came to you in June of 2020, first as a new patient, was she already prescribed other medications?
She was.
What were those?
She had been prescribed, so Percocet, oxycodone. Gynecology had prescribed her, I believe they were giving her 160 or 180 10 milligram Percocet per month. She was also on clonazepam, 2 milligrams.
Let me stop you there. What's clonazepam?
Clonazepam is a benzodiazepine, is an anxiolytic medication designed for both chronic long-term anxiety and acute anxiety, depending on how you take it. It's an older medication, it's been around for a long time. Really should not be used with opioids because they both cause respiratory depression, and most overdoses with opioids are related to the use of both benzodiazepines and opioids together.
Okay, so let me stop you there. Maybe, well, just so I don't forget, was she on any other medications, prescribed other medications when she began seeing you?
I believe phentermine.
What is that?
It's a stimulant used for weight loss. It's really only indicated for 6 months. And this, in fact, the state of Utah has basically taken it, said providers in Utah, licensed in Utah, really shouldn't use it. There's a strong discouraging. But when she came to me, she was on it, and that restriction hadn't been placed. And she'd been on it for quite some time. So it's a stimulant.
Okay.
Roughly an amphetamine-based stimulant.
Okay. And these were all prescriptions. Were you able to verify that these have been prescribed to her, or she's self-reporting?
No, those all come, you can review a year's worth of data in the state database.
Okay. So I want to talk, when she began seeing you and now she's your patient, you mentioned before that it is probably not a good idea to mix opioids with clonazepam.
Benzodiazepine,
With
yes.
benzos. Did you, I guess, what were you doing as her PCP to manage that or treat, or I guess help come up with a plan for that situation?
So there's a couple things we did. One is she'd been off, so benzodiazepines can have, with abrupt cessation after long use, can have pretty serious withdrawal, including life-threatening withdrawal, but she had already been off benzodiazepines. I believe it was for 30 plus days. That's long enough to say she's not going to have any acute withdrawal from the medication. So I did not prescribe those for her. So she was stopped on the clonazepam.
Let me stop you there. Is alprazolam or Xanax another benzo?
It is.
Was she prescribed those? Either, I guess that's the same thing, right? Xanax and alprazolam?
Alprazolam and Xanax, yeah, they're the same medication.
Was she prescribed that when she began seeing you?
No.
Did you?
Unless it was by somebody else.
Okay. Did you ever give her a prescription for Xanax?
No, and I verified it in the medical record a couple days ago.
Okay. So you mentioned that she had been off of clonazepam for at least 30 days at some point when she was a new patient. How did that affect the opioid prescription.
What do you mean, how did it affect it?
I guess your plan with her, your treatment of her.
So at that point, there's subjective pain. It's hard to say somebody's not in pain. So I continued the opioids at that point with a plan to taper those off. At that point, she had pretty high anxiety levels. I started her at some time in the first several visits on a medication called duloxetine or Cymbalta at 30 milligrams. It's a serotonin norepinephrine reuptake inhibitor, which means it increases the concentrations of serotonin and norepinephrine inside the brain.
So that sounds like an antidepressant.
So it is FDA approved for anxiety, generalized anxiety disorder, major depressive disorder, and it's also approved for musculoskeletal pain, fibromyalgia, and diabetic neuropathic pain.
So you started her on Cymbalta at some point in 2020?
At the beginning when I saw her.
How long was she prescribed that?
I think we went a year, I want to say close to a year, so we increased the dose to 60 milligrams. She had reported some good responses to pain. She started to have more pain, and at some point, I believe in 2021, I transitioned her to something called desvenlafaxine or Prestique, which is also a serotonin norepinephrine reuptake inhibitor.
Is it fair to call that an antidepressant?
This one is only FDA approved for depression, but it works the same as Cymbalta, and it actually works well for anxiety as well. So off-label use, and then off-label use for pain as well.
Okay. Primarily, it sounds like they might work for multiple things, like you said. Primarily, what was the purpose of the
Duloxetine.
yes.
And a lot of names, to target anxiety, depression, and pain.
Okay. I want to talk about her opioid prescription when she began seeing you. You said that she came to you with a prescription existing already of 160 to 180, 10 milligram a month. Is that correct?
Yeah, it was Percocet, which is a combination of oxycodone and Tylenol.
Are you aware of how long she had been prescribed that amount?
For a really long time. I don't know because I don't have the obstetrician's records, the gynecologist, not obstetrician, the gynecologist records. The nephrologist had been prescribing it for a number of months. So, and he wasn't, he's like, you need to have a primary care managing this.
The dosage that you talked about, 160 to 180, 10 milligram a month, would you consider that a high dosage?
For somebody that's naive to the drug, yeah, for somebody that's been on it for a long time, it's a moderate dose.
So for Casey, what would you consider it?
A moderate dose. Not something I'm willing, as primary care, not something I would be willing to increase, but a moderate dose.
What is opioid tolerance?
This development, reduced effectiveness of opioids over time. Benzodiazepines do the same thing. The effectiveness gradually is reduced over time as the body adapts to the medication and physiological changes make the medication not as effective. So basically, you can take the same dosage and your pain levels will be higher because the medication is now not as effective.
Would you say that Casey had a tolerance given how long she had been prescribed opioids?
She's been on the same dose and the pain levels were all reported about the same. I mean, she had periodically gone up and down on her pain levels. Everybody's going to have a little bit of a tolerance. Everybody's a little different as well.
But she's not complaining of escalating pain, that she's
No,
wanting more. And
she's not
higher
asking for
doses.
escalating doses. You know, typically, if there's a high tolerance, people will come in asking for escalation of the doses.
And you didn't see that with her?
No.
Sorry, I lost my train of thought. You said that you consider this a moderate dose for her, and that that's what I wanted to ask. I believe you mentioned that you had a plan to wean her down from that level of opioids.
Yeah, we also put her on something called amitriptyline or Elavil, which is a tricyclic antidepressant. It also affects dopamine, norepinephrine, and serotonin. It's used for chronic pain as well, and she was put on 10 milligrams of that at night to try to reduce pain, and the plan was to titrate that up as well. You do have to be careful with the duloxetine and the tricyclics not to get too much serotonin. But we were cautious, and she was fine. She didn't respond to this. She didn't have any symptoms of too much serotonin. So when pain went down, reportedly, pain is subjective, but her pain went down. And so over time, and I don't remember, we were able to reduce her down to just less frequent dosing on the pain medications.
And she was not, like you said, she wasn't coming back to you asking for higher amounts of opioids?
Not at the beginning. At the end, when her knee started to, there was requests. As the knee was getting worse, there were requests to go back up to the original dosing.
Okay, I'll come to that in a minute here. Well, actually, let's talk about that now. So you did not do the knee replacement, and we heard from, like I said, we heard from the surgeon that did. He talked about what he prescribed her after the knee replacement. Did you give her additional prescriptions other than what the surgeon gave?
No, he managed the pain. She had 2 knee surgeries. She had the one, I believe, on 6/20/2024, and then she had the knee replacement, I believe, 7/25. So she had 2 knee surgeries fairly close together.
Let me stop you there. We've heard about the knee replacement in July of 2024. What's this first knee surgery that you're talking about?
It was an arthroscopic surgery to go in and clean up some of the frayed tissue and the damaged tissue and cartilage on the knee, and to see if that gave her adequate pain relief so he could buy more time for replacing the knee, is what I believe. I'm sure he's already testified as to what his intentions were with that.
Do you know if the same surgeon performed that first knee surgery that ended up doing the replacement?
I think so. I can't be certain. I'm pretty sure it was the same, but I'm not sure.
Okay. But is that first knee surgery something that you can independently verify, or is that just word of mouth by Casey?
No, I believe there's a note in the chart now. It's actually uploaded into the electronic medical record.
You mentioned that you did not give her any prescriptions after the knee surgeries. Were you aware of what she had been prescribed by the surgeon?
I think he gave her, and this is just looking at the record, I saw a prescription for hydromorphone, which is often used in conjunction with oxycodone. I believe that's, looking through the medical record, I saw a prescription around that time frame.
Okay. Is hydromorphone also an opioid?
Mm-hmm. It's called Dilaudid. That's what most people recognize it as.
You said that around the time of her knee surgery, she did complain of more pain and was asking maybe to go back up to the original dose of opioids. Is that?
Yes, she was.
What did you do in response to that request?
So when I started prescribing again, I believe we went back up in the recovery. At some point, I had gone back up with the notion that she was going to have to see a pain management doc at that point.
And why was that your notion?
Because me managing her pain, the idea was to reduce opioid medications with alternatives and figure out ways to manage her pain. And the knee surgery, or the replacement and the planned other replacement were the primary pain generators. Well, I shouldn't say that, the abdominal pain as well, but at that time, those were the primary pain generators. And as we got rid of some of her pain with the surgeries, if they were successful, the idea was to get her down on the dosages of the pain medications.
And you would have turned to a pain management doctor
To go up or escalate the doses, she would need to go to pain management.
Okay, so your plan was never to escalate the doses beyond what you already had?
No, I couldn't do that.
I want to talk about the frequency of treatment or communication that you had with Casey. How often were you seeing her in person?
A couple times a month, maybe.
Is that normal for a primary care physician with somebody with her conditions?
Yeah, it's not uncommon.
Was she communicating with you by other means?
I had called her on my cell phone. I usually go through Doximity, which is it reroutes it through the University of Utah calling number and shows that. So yes, she had gotten my phone number because I probably forgot to use Doximity and called her on a result or something. And so yes, she had texted me several times after the knee surgery, telling me about the pain in her knee.
Is it normal, you said you normally go through some kind of program that converts your personal cell phone number into something different. Is it normal to text with patients on your personal cell phone?
Not if I can help it. I just changed my phone number because of it.
And she was reaching out to you because she may have gotten a hold of your number.
Yeah, she was telling me she was in pain, so we were scheduling appointments.
How frequently was she texting you?
I don't remember. It was only a couple times.
How
I
often,
remember.
how often were you responding, if you remember?
I would usually have the nurse call her and schedule an appointment.
Did you ever go to her home?
No.
To your knowledge, did any nurses that you work with ever go to her home?
No.
Was Casey ever on hospice care?
No.
I think I asked you, did Casey ever have cancer?
No.
Did Casey have diabetes?
No.
Did Casey have any medical need for insulin?
No. In fact, she had complained, you're probably going to ask me about this, but she had started in 2023, I believe, complaining of low blood sugars, hypoglycemia.
I guess, is that something that she's just subjectively complaining about? Is that something that you're able to objectively verify?
You can verify it. So all the labs we frequently will do with her kidney function, that usually will check a glucose. So all of the sugars from the lab work were normal. Now I did order her a glucometer, the same thing that a diabetic would use to check their sugar, poke their finger, get a sample of blood, see what the sugar is. And she would send me sugars that were low. I was looking at the values and they would be in the 50s, so she would report morning sugars were probably the worst, usually in 52 to 55 range, or 50s to 60s in the morning.
Did those reports that she gave you seem consistent with otherwise what you're observing about her?
It was pretty sudden. The hypoglycemia, these hypoglycemic episodes were pretty sudden, started pretty suddenly. So we did a workup on her, right, where we have to look for causes of hypoglycemia. Causes of hypoglycemia for diabetics are going to be medications typically. For non-diabetics, there's a number of things. The most common is called postprandial hypoglycemia, associated with eating. A huge load of carbohydrates will trigger the pancreas to oversecrete insulin and drop the sugar. Hers were not associated with eating. There was no postprandial. These were random. Blood sugars were dropping very, very low, mostly in the morning from what she was reporting.
So you issued her, or I don't know, gave her a glucometer to take home, and then she was reporting blood sugar levels back to you. It wasn't something that you were looking at the glucometer and verifying? No, she would just tell me the numbers. I don't believe she ever had the glucometer with her for me to independently verify the numbers. So I never saw the numbers, and like I said, all the numbers that we had inside the clinic within the electronic medical record were normal. Okay. They were all in the anywhere from 70 to 90 range. The ones that she was reporting to you that seemed abnormal or sudden, like the 50s, were you able to come to a conclusion about what might be actually medically causing that?
No, so we checked, I checked for a few other things. We ordered a bunch of laboratory testing. Sometimes this is hard to prove and sometimes requires, for example, if somebody has an insulin secreting tumor on the pancreas, this can be fairly difficult, but the lab work didn't identify. I checked a lab called the C-peptide, which returned at 2.9. What C-peptide is when insulin is activated inside the body, it breaks into two products. C-peptide is released, and we can measure those levels, and that tells me what somebody's endogenous insulin. By endogenous, I mean their natural pancreatic production of insulin is. Her levels were normal, and at the same time, I always will compare sugar at the same time, and her sugar was also normal at the time of that C-peptide.
Okay.
So if somebody has an insulin-secreting tumor, often in a fasting state, they will have, and I had her come in a fasting state for that. Her sugar was, I believe, 86 at the time, and the C-peptide was right in the middle normal range where we would expect the pancreas to be functioning.
So were you able to rule out an insulin-secreting tumor?
Not completely with that, but it would be pretty hard to say somebody has one without a pretty constant high level of insulin.
Okay. Any reason for her to be taking insulin?
No.
How would insulin have affected her?
Insulin will drop her sugars. So insulin allows cells to take up sugar from the bloodstream, right? So insulin is our way to get sugar out of our bloodstream and into the cells of our body for energy purposes. And so it would drop her sugars pretty drastically.
Pretty drastically?
Yeah, I mean, for somebody that's not diabetic, most people are going to have a pretty bad response to insulin use.
Even a small amount, perhaps?
Even a small amount. I mean, that's a harder one because everybody metabolizes drugs a little bit differently, so it's hard to predict the pharmacokinetics on, right, there's a range with drug durations and how long they last and so forth in every individual. So every individual is different. So we metabolize drugs differently.
I want to switch gears a little bit. We've talked about a lot of different medications that may have been prescribed at different points for anxiety and or depression for Casey.
Mm-hmm.
So it seems clear that she talked to you at least about her levels of anxiety and depression.
Mm-hmm.
How, I guess, severe, I think you said that you did do some kind of diagnostic or I don't know, some kind of way to gauge the levels. Is that fair?
Yeah, so we did what's called the PHQ-9 and the GAD-7. So PHQ-9 is a 9-question depression screening. The GAD-7 is a 7-question anxiety screening. I think we have 4 on record. Most of them are associated with social work visits. The depression screening was ranging 21 to 22, which is moderate to severe depression. And the anxiety screening levels were at 18, which shows severe anxiety.
Were those consistent among the tests that you had
They
given?
stayed the same the whole time.
Did she ever, did you talk to her about suicidal ideation?
Yeah, we always talk about it. Every time we talk about depression, we talk about suicidal ideation. One of the questions on the PHQ-9, have you ever thought about suicide? I'm probably quoting it wrong. And it's no days, some days, half the days, every day. And she would mark a 2, which is half the days.
Okay, was that significant to you?
Yeah, it's always significant. We've got her in, tried to get her in to see our therapist. She was seen, I think, 4 times by our therapist and called probably half a dozen other times. Social worker.
In what time frame?
2023, 24.
Okay, so she went 4 times to a therapist and then maybe called, did you say half a dozen?
The therapist tried to call her if there was some concern at a visit that I had seen her on, like a televisit or something.
Okay.
Yeah.
Did Casey ever express a plan to commit suicide to you?
No plan, no intent, which was also documented in the social worker's notes.
Is that different? So I think you mentioned the test asks if you ever think about suicide. Is that different than if somebody expresses a plan or intent?
Absolutely, right? I mean, people go through ups and downs, people go through breakups, people go through job loss, they go through lots of things, and people get depressed. Most people have periods of depression, and most people have periods of time when they say, it'd be better if I wasn't here. But they don't actually have a plan to go through with it. Now, if there's intent, that changes it. If there's intent and plan, that increases the risk of actual suicide, because now that is a thought that is, how do I say this? The thoughts have accelerated.
Okay, they're
Right.
putting more action into
Right,
the
there's more potential, yeah, there's a lot more investment in that thought at this point. And so she never had expressed any intent.
So it sounds like depression and anxiety were concerning enough to you that you put her on medications, maybe referred her to see a therapist a few times. Any other escalation that you saw needed for her levels?
No, nothing ever required hospitalization, either with me or the therapist.
Is that something that you would have done if you saw something that was
If-
concerning?
If there was concerning, absolutely. Sent her to the emergency room or an acute crisis center.
Do you remember when the last time you saw her before her death was?
It was in July. I think she saw the nephrologist on the 25th, and I think or no, she had the surgery on the 25th. I don't remember, honestly, I don't remember the dates. It was, I did a televisit with her.
Do you remember if it was before or after her knee replacement?
I think it was after the knee replacement.
I want to talk about that. Do you remember that encounter?
Yeah, she wasn't talking about the knee at that point. It was more this weight gain that she had.
At this telehealth visit, did she, I guess, anything about her presentation or what she told you suggest to you that she was suicidal at the time?
No. No, she was actively seeing me. She was seeing the nephrologist, had plans for other visits, had scheduled a number of visits with endocrinology, cardiology.
And how do you know that she had scheduled other visits with other specialists?
I just saw them in the computer. I can see the future appointments through the University of Utah.
Do you know how many future appointments she had scheduled?
I think it was 4.
Do you know how far out in time those?
I didn't look at the dates.
Okay.
I didn't look at the dates.
Did she talk to you about any other future plans she had just for her personal life?
And we talked about well, honestly, she was very fixated on this weight gain, which we, in the end, concluded that she was just gaining body weight. This was just body weight. It wasn't her kidneys, it wasn't her liver, it wasn't her heart. Was she coming to you to work up some kind of plan to help her lose weight? She kept telling us there was this edema that kept coming on her legs, and her legs were getting really swollen, but nobody ever saw it. So we had, all this was right before she passed away. So we hadn't really come up with any concrete plans because we were still looking for objective information on the swelling in the legs and the weight gain.
Okay, so it sounds like, and I think I've asked you this before, you had an impression that Casey may have been exaggerating or fabricating health conditions that you weren't able to objectively verify.
Yeah, she did in this case. I mean, 3 of us, there's documentation of 3 of us pushing her on her legs. In fact, the ER, she came in complaining of pain from swelling, and in their note, they said trace edema in the legs, which means almost none.
Based on your training experience and direct experience with Casey, do you have an opinion about why she may have been exaggerating or fabricating health conditions?
And some of this is going to be opinion, right? And this was opinion among myself and the staff. She liked attention.
And what gave you that, what leads you to that opinion?
There was always something. She was calling Terry Baird, the case manager, a lot with various complaints and concerns, and she seemed to call a lot and like somebody involved. And we knew that at least what we thought was, we know she'd been had lost a relationship when I first started seeing her, and home life and other things, didn't have a lot of people in her life. So we had presumed that she liked the attention from the healthcare setting, just with the amount that she was trying to interact with us.
Okay. I'm going to switch gears a bit. You being a physician, it sounds like do you work with nurses?
I do.
Do you depend on nurses to help you do your job day to day?
Every day.
Would you say you're aware of the, I guess, base level of knowledge and kind of categories of knowledge that you expect a registered nurse to have?
Yes.
I'm going to show you what's been marked as State's Exhibit 7, and I don't intend to actually admit this, but I do want to use it as a demonstrative that we'll publish with the jury. Mr. Williams, I believe, has no objection to that.
I have no objection.
State 7, did you say? That's already been in.
11.
Oh, 11.
So I'll show you that on your screen, and if we can put it on the screen for the jury as well.
And no objection, Mr. Williams?
I'm sorry, no objection.
Thank you.
Trying to find a different document, I'm sorry.
Push it.
The jury will receive more context about what these are from with a later witness, but I want to go through some of these, or all of these with you. And we'll start at the, do you see this on your screen?
I do.
I'll start with the top one. So on March 13th, 2024, there's a report. What's BP?
Blood pressure?
What does BP 60/39 mean?
So top number, do you want me to explain blood pressure?
Yes.
Yeah, so top number is systolic blood pressure, bottom number is diastolic. Diastolic blood pressure is the blood pressure present in our bodies in between the heart beating. So that's our baseline pressure inside our arterial system. And then the top number represents the pressure as the heart is pushing the blood through the body, what the pressure in the body is during that beat.
What is, understanding this may vary within people, but what's like a normal blood pressure range?
90 to 120 on the top number, 60 to 80 on the bottom number.
So to you, what does a blood pressure of 60/39 indicate?
My interpretation that something critical is going on and needs to be addressed. Now, that's a critical blood pressure.
What would somebody with a patient with a blood pressure of 60/39, what symptoms might they be exhibiting?
Lightheaded, passing out, pale, sick appearing, clammy.
Would you expect a nurse to know this?
Yes.
The next one, March 14th of 2024, oxygen is 39, heart rate is between 24 to 28, blood pressure is 52/30. What do those vitals mean to you?
Either the person is passed out on the floor in an ambulance or they're not real. I mean, oxygen at 39 is not compatible with life.
Would you expect a nurse to
For
know
very
this?
long, yeah.
Next one, March 16th of 2024, blood pressure is 40/30, heart rate is 22 to 26, oxygen is 32. What do those vitals say to you?
They'd be unconscious,
Would you expect a nurse to know this?
yes.
Next one, March 17th of 2024, BP is 39/20, oxygen is 24, heart rate is 24. What do those vitals say to you?
It says I'm literally struggling to try to breathe and my heart rate's 24. She wouldn't be, I'm assuming this is a text message, she wouldn't be texting with these. And yes, a nurse would realize that she would not be texting with these vital signs.
Next one, March 18th, 2024, blood pressure 30/20, oxygen is 22. Again, no wonder I'm struggling to breathe and my heart rate is still around 24. What do those vitals say to you?
That they're not real and somebody that's texting.
So somebody with the, I guess, are those vitals even compatible with life?
No,
And certainly somebody would not be texting then.
no,
Would you expect a nurse to know this?
yes.
Next one, March 20th of 2024, oxygen is 22, heart rate was 24, blood pressure was 19/20, or maybe 19/30. Are those vitals that are compatible with life?
No,
Would you expect a nurse to know that?
yes.
March 28th, 2024, BS, what blood sugar perhaps?
Yeah, blood sugar,
116, blood pressure 16/30, O2, I'm assuming it's oxygen, is that fair? 20 to 22, heart rate is 24 to 25. What are those vitals compatible with life?
No, they're not. In fact, the blood pressure, the systolic is lower than the diastolic, which can't happen.
That can't even happen?
No,
Would you expect a nurse to know that?
I would.
Next one, March 30th, 2024, what is PB? If you know.
I don't know.
Maybe
I think probably is supposed to be BP.
okay, so maybe a typo
I
meant
think it
blood
was a typo.
pressure. 15/0, oxygen is 19, heart rate is 23. Are those vitals compatible with life?
No,
Would you expect a nurse to know that?
yes,
Same date, temperature is 104.6, oxygen jumping between 17 and 21, heart rate is 14 to 17, blood sugar is 46. What do those numbers indicate to you?
low blood sugar, not compatible. You can't have a heartbeat of 14 to 7 and be alive,
Would you expect a nurse to know that?
or you're very close to death. I would.
March 3rd of 2024, blood pressure 20/0, heart rate 27, oxygen 24. Are those vitals compatible with life?
They don't make sense, no. They're not, but they don't make sense.
Why don't they make sense?
Because you've got zero arterial pressure with the diastolic pressure when your heart's at rest, but if your heart was still beating, I suppose, with no pressure, but a nurse should understand that those don't make sense.
Next one, March 8th of 2024, blood pressure 30/0, heart rate 17, oxygen 21, temperature is 87, and blood sugar is 43. Are those vitals compatible with life?
No,
Would a nurse know that?
yes,
April 14th, 2024, her heart rate has been in the low 30s, her oxygen has been between 19 and 21, and her blood pressure is 17/0. Are those vitals compatible with life?
no,
Would you expect a nurse to know that?
yes,
April 20th, 2024, heart rate 21, oxygen 16, blood pressure 17/0, temp has dropped to 84.2. Are those vitals compatible with life?
nope,
Would you expect a nurse to know that?
yes,
April 21st, 2024, blood pressure 20/0, heart rate 14, oxygen, I believe 14, between 14 to 20, jumping back and forth quite a bit, temperature is 78.4. Are those vitals compatible with life?
no,
Would you expect a nurse to know that?
yes,
April 23rd, 2024, heart rate 167, oxygen 42, blood pressure 97/64, temp is 94.6. What about these vitals?
yeah, they could exist, she'd be blue, and that's a very low oxygen level, but yeah, those could happen.
Those could happen, but what would I guess you said she'd be blue, any other physical symptoms you'd expect?
With an oxygen level of 42 and a temperature, heart rate of 167, probably be passed out.
Same date, there below, heart rate 36, oxygen 21, blood pressure 32/10, temperature 94.6.
Same thing, not compatible. with
Would a
life.
nurse know that?
Yes,
April 26, 2024, heart rate 72, blood pressure 46/24, temperature is 66.4. Are those vitals compatible with life?
nope,
Would a nurse know that?
yeah,
May 2nd, 2024, heart rate is 29, oxygen is 18, blood pressure is 18/10, temperature is 90.4. Are those compatible with life?
they're not,
Would a nurse know that?
yes,
Did I already do May 6th? May 6th, 2024, heart rate's 30, oxygen is between 17 and 20, blood pressure is 37/24, temperature is 67.2. Are those compatible with life?
nope,
Would a nurse know that?
yes,
May 8th, 2024, heart rate is 22, oxygen is 19, blood pressure is 26/14, temp is 70.4. Are those compatible with life?
no,
Would a nurse know that?
yes,
May 9th, 2024, heart rate is 14, oxygen is 11, blood pressure is 14/0, temperature is 64.2. Are those compatible with life?
no,
Would a nurse know that?
yes,
May 10th, 2024, heart rate is 10 to 13, oxygen is 14 to 16, blood pressure is 14 over 0, temperature is 60.8. Are those compatible with life?
They're not, no,
Would a nurse know that?
yes.
I'm going to skip down, save us some time. Let's go to anything around August, if there is. Or, okay, late July. We'll just do with these final three on this exhibit. So starting with July 12th, 2024, heart rate is 29, oxygen is 9, blood pressure is 31 over 24, temperature is 86.8. What are those vitals say to you?
Same thing, not compatible with life,
Would a nurse know that?
yes.
July 13th, 2024, heart rate is 12, oxygen is 8, blood pressure is 12 over 10, temperature is 76.4. What do those indicate to you?
Not compatible with life,
Would a nurse know that?
yes.
July 18th, 2024, heart rate is 9, oxygen is 6, blood pressure is 19 over 14, temperature is 78.6. Are those compatible with life?
No,
Would a nurse know that?
yes.
We can take down that demonstrative. Thank you. Would you expect a nurse to understand what insulin might do to a non-diabetic patient?
Yes,
Would you expect a nurse to understand what effect, sorry, that's, re-asking that. Would you expect a nurse to understand how hospice care works?
yes.
How does hospice care take place?
When you determine somebody has a terminal condition with a limited time to live, we will offer hospice, comfort care, and increased support through end of life.
Is that typically something that happens at the person's home?
Can happen in the home or in a hospice facility.
I think you said that I forget, I'm gonna misstate exactly what you said. They're near end of life?
They have a terminal condition. Death is imminent. Usually we'll say prognosis is within 6 months.
So it would be atypical for somebody to be on hospice longer than 6 months?
In the current setting, no, because of a lot of our older population that have terminal conditions. Again, everybody's a little bit different, and predictability is not between people. It's hard to directly predict when a condition is going to take someone. So we will extend it if it is a terminal condition, and we anticipate when we put them in hospice, the prognosis is usually about 6 months, but we will extend it. And sometimes I've seen it extended for years if in, for example, an individual with dementia that has just kept going.
Okay, somebody with Casey's condition, near the end of her life, is she somebody that would have required hospice?
Absolutely not,
Would she have required hospice for multiple years?
no.
Do you know what HIPAA is? What is HIPAA?
Protection of health information from being disseminated to people outside an individual's care. So protection of their health information,
Are
rules that
medical
guide.
providers subject to HIPAA?
Absolutely.
Does that include nurses?
Uh-huh.
Would HIPAA allow a nurse to communicate health information to a patient's friend over text message?
No,
Would HIPAA allow a healthcare provider to use the patient's own phone to communicate health information to somebody else?
no,
Would HIPAA allow nurses to communicate health information? Would you expect a nurse to understand how HIPAA works?
yeah, we go through every school in healthcare goes through extensive training on HIPAA, and refresher courses are required annually.
What's a DNR?
Do not resuscitate order.
How do those work? I guess what's the procedure if one is in place?
So DNR is a decision between a physician and the patient to perform no resuscitation in the event of an emergency, for example, cardiac arrest. DNRs are signed by a healthcare provider in the presence of the patient.
Are they kept on file somewhere?
They are, so the hospitals will keep them. We keep them stored in our database as well.
Is that something that you would verify before you actually decide not to resuscitate somebody?
Yeah.
Would you expect a nurse to know that?
Yes.
Do DNRs mean, I know that it literally means do not resuscitate, but what exactly, and understanding this may vary based on the individual, I guess, agreements that people come to with their physician. Does it mean that you literally can't touch a patient, that you can't do anything?
So DNR is nothing, right? DNR is an order that we are not to resuscitate, no CPR, no basic life support, no advanced life support. So advanced directives are a little bit different. That is a patient-guided document that outlines what they want if there is something to happen.
Okay, so an advanced directive can give more nuanced guidelines about what they want?
Yeah, a DNR is a physician order. It is in conjunction with patient's decisions, but it is signed by a physician as an order saying this was discussed and this is what this individual wants, no resuscitation attempt at all.
And you would have to verify that before acting on that?
Yes.
And you would expect a nurse to know that?
Yeah.
With advanced directives, where there may be more nuanced guidelines or wishes,
Yeah.
how do those work?
Yeah, so advanced directives, we will give the individual some paperwork to go home, talk to their spouses. They make decisions as far as do they want mechanical ventilation? Do they want assisted breathing? Do they want assisted nutrition? Do they want, so the things are for basic life support. And they can outline what they want, what they don't want. And then, so it's just a decision-making. Living will also encompasses medical power of attorney. So.
Did Casey have a DNR?
No.
Did Casey have an advanced directive that gave more nuanced, I guess, guidelines on what she wanted or didn't want?
Not that I filled out with her, or that I had seen.
Would you expect a nurse to know how advanced directives work?
Mm-hmm.
Would you expect a nurse to know how to go about trying to verify that?
Yeah, I would.
You mentioned within the advanced directive that may encompass powers of attorney, medical powers of attorney. What does that mean?
So medical power of attorney is giving permission to someone else to manage your health care in a time of crisis or end of life or serious injury.
Is
And
that
what
okay?
they do it in accordance with the directives that you have written down on your advanced directive paperwork.
So that would be part of an advanced directive.
It's all, the medical power of attorney, no, the advanced directives can be filled out separate. That's literally just a form that we give them and they fill it out. But it usually, they can do, they're all part of the same spectrum of managing end-of-life care or serious situational care.
Okay, so if somebody's electing to give another individual a medical power of attorney, how might that other individual become aware that they've been selected?
Well, they have to accompany them, right? This is all signatures and going through the legal framework with a lawyer, notary. It's all, it has to be done by the book.
With a physician, signed paperwork, notary?
Yeah, I mean, that can be done, it's usually done with will and estate planning through an estate lawyer.
Okay, so not necessarily, a physician doesn't necessarily have to be involved, but
No.
there's some kind of authority that
Yeah, there has to be, right? I mean, decision-making for healthcare.
did Casey have a medical power of attorney to your knowledge?
Not that I know of,
Would you expect a nurse to know how those work?
yeah.
How do death certificates work?
Somebody passes away, and then either myself as the primary care physician, we will sign them through the state database, or the ER doctor will sign them.
Does it need to be a physician that signs a death certificate?
I believe so. And when I say PAs so nurse practitioners can also sign them.
Okay, can nurses sign a death certificate?
No,
Would you expect a nurse to know that they can't sign a death certificate?
they won't have access to they won't be asked to.
All right, the jury's going to be given a little more context about this topic later also, but it pertains to you as well. Did you have plans, well, let me ask you this. Did Casey's body have a problem absorbing or ingesting medications generally? Such that like medications just don't work on her?
I mean, she did have bariatric surgery, which does alter the gut and absorption of some things. For her iron, we know she was iron deficient, which is probably multifactorial, heavy menstrual bleeding. She subjectively said she had rectal bleeding frequently. She was supposed to see a gastroenterologist for that, and then as well with the gastric surgery. I believe she had a gastric sleeve, which doesn't usually confer as much absorption issue as a bypass surgery.
Okay.
So with the bypass surgery, you're literally bypassing the stomach and the upper small intestine. And so we connect you basically cut the stomach out, the stomach is free floating. So nothing, the item or the nutritional elements that normally absorb in the stomach and the upper small intestine now no longer absorb because the stomach is bypassed. With a gastric sleeve, they make the stomach smaller.
Okay, and she had the latter?
Yeah, she had the sleeve, but they still often will have absorption issues.
Okay. It sounds like, though, that she was on a number of medications that you were prescribing her. Were those seemingly effective?
She would say they were. I mean, I'd have to go back to each individual note and see what she said about them, but the duloxetine was initially effective for her anxiety. It was helping with pain. Then it wasn't. The Prestige or desvenlafaxine was effective, and then it wasn't. And the amitriptyline she stayed on and said it helped with pain.
So it sounds like she may have had some valid absorption issues with medications. If I told you, would Casey have been somebody that if she ingested 9 vials of insulin, her body would not react in any way to that?
No, insulin's not ingested though.
I guess that's my wrong terminology. If 9 vials of insulin is introduced to her system, was her body such that would do nothing to her?
No, because it's going directly into her bloodstream.
So
Right,
she didn't have any.
Or it's being injected, it's being absorbed into the bloodstream, not through the gut, right? So insulin is either subcutaneous, could be IV or IM. It's not done very often, IM, because that increases the rapidity of delivery, and so that's intramuscular.
Okay.
So subcutaneous, intramuscular, and IV are the 3 means of injectable delivery of drugs to a human directly through the vascular system.
So even her absorption issues with medication, that would not affect how insulin may.
No, we're bypassing the absorption in the gut.
Did you have plans to arrange a surgery in the Pacific Northwest for Casey, to get a surgery that would allow her body to respond to medications such that she could kill herself?
No,
Are you aware of even such a surgery
I'm not
exists?
even aware of a surgery.
Is that something that you as a physician would coordinate or help a patient plan?
No,
Was Casey on any secret heart medications that you were giving her?
secret medications, no. She was on metoprolol, which is a beta blocker, it's lower heart rate, but it wasn't secret, it's in the medical record.
Was she on any heart medications that you were prescribing her that would allow her to more easily be able to kill herself?
No.
Would you expect a nurse to know that those things are not real?
Yes. And if not, look them up.
I have nothing further. I'll pass the buttons. Well, yeah. It's 4. That was-
Let's take one short break. We're going to go back on the record on case 251-401-132, State of Utah versus Sundwall. Dr. Masteller, I will remind you, you are still under oath. Mr. Williams.
Thank you. Good afternoon, Dr. Masteller.
Good afternoon.
How you doing?
I'm good.
That was exhausting. I'm not gonna go over all of that again. Let me hit some themes about Casey. Let's talk about Casey in general. You were just wanting to put through all of this, obviously, I mean, on its face, baloney vitals that apparently were sent by her, right? Yes?
Yeah.
Sorry, I have to remind you. I'll be the bad guy reminding you to say yes if you just nod.
Yeah.
Okay.
Yes.
And, I mean, you had already said that it's fair to say that Casey was a patient who gave false information, or at least supposed subjective information that wasn't verifiable, even in your experience with her, right?
Yes.
And sought to come in and have visits and go to the ER and things. I think you once referred her to the officers as a frequent flyer. Does that sound right?
Yes.
When she reported false information or subjectively described ailments that just were not verifiable, fairly, you gave your opinion that she did it for attention seeking, right?
Yes.
You saw that as attention seeking even in the medical circumstance, the medical environment, right?
Yes.
Now, a lot of times as a doctor, that's really all you have is subjective information to go on, right?
Right. Yes.
Some of the things, it's like especially for instance, mental health. That's a tough one, right? Someone says they're depressed, you can't measure it.
I mean, we use our scales,
You're not a psychologist.
but they're answering the questions. So it's all subjective.
Okay, that's my point, is that you use some scales that you marked down. She scored high enough that you referred her to a mental health provider at one point, right?
On several occasions, yeah.
She went once for 3 visits. You recall that from your records?
No, she didn't go very often.
But I told you, according to the records, it was 3 times. Do you have any reason to disagree with that?
No, I looked at it. I thought it was 4, but 3 or 4 were all the visits, and then there were several telephone encounters where the social worker couldn't reach her.
Right. So while she would express suicidal ideology, depression, anxiety, and these things, and was referred out to resources, it doesn't appear that she went to those referrals, other than the 3 mental health visits, correct?
Yeah. Nope, she did not.
And that applied to other things, like you sent her to an endocrinologist, right?
Right.
She never went to the endocrinologist.
No.
And when she would talk about some things that are measurable, and you got her in there to measure, didn't pan out. Your measurements didn't verify what she was claiming, right?
Not usually.
Let's talk especially about something that's relevant to this trial, glucose levels, all right?
Right.
So, I'm sorry, I meant to put these up there for you in case they help you on paper, but I'll publish them as well if we can. I'm gonna show you, those look like just a couple different sections of her medical records from back in 2020.
2023, 9/14/2023.
I'm sorry, there are 2 different ones.
Oh, yeah,
I screwed
9/26/2020.
up. I screwed that up. In as far back as 9/26/2020, let's talk about that one. She's in addressing supposed hypoglycemia, right? Look at it, I know there's a long paragraph, and the second page might help. Take your time if you'd like to.
Oh, yeah, yeah. So She addresses some hypoglycemic concerns, yeah.
I'd like to put this up, to publish to the jury as illustrative so they can follow along while I address some of it with the witness, though I'm not seeking to send it back as an exhibit.
Ms. Hunt?
No objection.
Thank you.
Mike? My computer, it fell out, so when it loads up again, you can publish it. In the meantime, let's lay a little foundation. So here we are, all the way back in 2020, and she's your patient by then, right?
Mm-hmm. Yes, she is.
And we've got the subject of hypoglycemia, correct?
It is, yep.
You're dressing, and you had already said that in general, you recall that when she would have these claims of hypoglycemic problems, you just could never verify them. Right? When you were in the lab, she'd be, I think you just said between 70 and 90 when you actually used medical equipment to test her blood sugar levels, right?
They were always normal. I don't remember seeing a single hypoglycemic.
And I think just for numbers purposes, you had said 70, 90, that's what you recall, right?
That's what I recall.
In the lab.
Yeah, ranging between 70 and 90.
And let's talk about when one of these occasions where you had me doing this, as usual, poor. So what happened is, even back then, you went ahead and said, go use a glucometer and let us know, report your levels, right?
Right.
And then this is a log, as I scroll through this, of levels that she reported. This is to you, the doctor, in 2020. That's what this is a patient log calling in and telling her what her glucose levels were, right?
Yeah, that was part of the note, so it was, copied and pasted into the note, probably.
Yeah. So she's reporting these levels, 62, 51, 68 over that period of time on the 4th. I mean, if we're gonna go over stuff that Casey reported, let's still go over what she reported to her doctor. That's the first day on the 4th, right?
It is.
Not one of those is within the level you ever measured. Let's go to the 5th. As low as 54, 60, 71, right? That's what that says on the 5th.
It is.
54. There's no indication that your team took any action when Casey Terry told her doctor that her blood sugar is at 54, right?
I don't remember.
That's a significant blood sugar level that would be alarming, agreed?
It would, yeah.
Well, let's go, because it goes lower. The next day, she says she's 52, then she goes to 47. That's close to unconscious, perhaps, right?
For some people, yeah.
The doctor does that. Would that alarm you as a doctor?
Yeah.
Then on the 9th, she's down to 53 again, 71. Looks like the 9th is, at 8 p.m. on the 5th, we hit the 71. The first one that's even, it's 1 point within the measurements that you ever took, right?
Right.
Got 52 again the next day. She is repeatedly reporting 52, 53, 52, 54. This person is waking up in the morning and saying that's her blood sugar level, right?
Yes.
No indication in the charts or anything that the doctor's office called an ambulance, right?
No.
No, doctor's office didn't. Otherwise, it doesn't appear from this even respond to her, communicate with her about these.
They were already done, right? So these are passed.
Well,
so,
how do you know? I mean, you said they were copy and pasted in.
right, but it's past blood sugars. Those are previous blood sugars from
Sure.
previous days.
That's true. If you're
So if we check her blood sugar on the day that she's here and it's normal,
yeah, well, do you know? I mean, you're her doctor. Do you know whether these were reported each day?
I don't think so.
Why not? Why don't you think so? She's trying to report her medical condition, don't you? Wouldn't you tell her to do it every day?
Depends on what the blood sugars are.
It would, wouldn't it? I mean, she's coming in saying she's got low blood sugar. She's waking up dizzy, reporting blood sugars. Let's go through them again, and at the end, we'll talk about the same question then. at some point, they end up in a chart, right?
Yeah, when she comes in for the visit, or we did a televisit.
Can you tell from him this when it was?
26th of September.
Okay. So this can't, she's relating through up until the 26th of September, right?
Right.
So at least on the 26th of September, you agree that these items, these readings are known to your office?
Right.
All right. On the 11th, she said, I was a 46. 46. That's pretty dang alarming, right?
Yeah, it is 43, 46.
40,
Very, very alarming.
Extraordinary alarming. Can we agree? I mean, we've had earlier testimony, you've given it at other hearings. That could even render somebody unconscious, agreed?
Yes, it could.
Especially in combination with a whole bunch of other medications on board. Opiates, benzodiazepines. I know that you weren't prescribing benzos, but you know now that she was taking them, right?
Yeah, I heard she was.
54. Then she comes in. Patient will need to get a ride at the clinic. You say she should come in, she should fast, things like that. Certainly she was never sent to any emergency room or anything like that, right?
Not at this time.
And as you saw this, in fairness, you see all these reported levels. You don't believe for a second that she was telling the truth about those, do you?
I'd question them.
I don't know why you resisted. We just went through them. Those are not levels of somebody you believed. Especially since when you tested them, they weren't even close to that. In a laboratory, they were normal every time you tested them.
And
right?
I would expect her to be symptomatic and immediately rush into the emergency room or the clinic.
Those are more indicative to you probably of her inability to tell the truth and maybe has some mental health problems trying to make a doctor believe this sort of data, right?
Yeah.
Yeah.
Yeah, at this point, I'm sure I was already questioning things.
And then that's in 2020. I mean, it continued. You pointed out that I had started you off on the wrong. Let's go to another report here. Because in fairness, here's a report all the way into September of 2023 on the subject of hypoglycemia, correct? Look it over if it helps. I'm sorry. I meant to show these to you at the break.
Yep, another complaint, dropping to 39.
39. She claimed that she had a 39. That is deadly, agreed?
Yep.
When she claimed that, you didn't believe it, right?
Well, I knew she wasn't at the time when she was here in the clinic.
You didn't believe she was when she claimed she was 39. You didn't believe when she said, Doc, I woke up at a 39. You don't believe that, right?
I've had people wake up at 40. They usually go by ambulance to the ER.
Yeah, I thought we had a prior hearing about this. This is emergent
Yeah,
numbers.
they usually go to the emergency room by ambulance.
So, I don't know what the resistance is, but isn't it true that since they would normally be sent to the emergency by ambulance, you don't believe the information your patient is giving you? You don't believe it, doctor.
Yeah, I ordered stuff to check it. Again.
What's this insulin? What's this reference to an insulin plan?
That's checking fasting insulin levels.
Okay.
Yeah, that's checking fasting insulins, that fasting C-peptide that I talked about.
Trying to do some tests because once you did them, you knew that there was no reason to believe that she was even abnormal, let alone at a 39, right?
Yeah, her sugars were normal on her C-peptide, and this is the one specifically, I believe, on the 14th when we did the C-peptide level, and she came in and the sugar was 86, and the C-peptide level was 2.9, which is a representative of her insulin production.
Very normal.
Very normal.
You were asked a lot of questions about these opiates, and along the same lines, I want to go to something that you mentioned. Got a screen on the screen here. You indicated that as a doctor, you're able to look at what you called a Doppel record, right?
Uh-huh.
The Doppel record is a division of professional licensing, right?
It is.
So what it is doctors can look up at what's going on in professional licensing activity in the form of prescription medications, right?
They can, yes.
And you can do that right from your office.
Yeah.
And do you think that's a good thing to do when you're prescribing opiates?
It is, and they've made it much easier.
And part of the problem they made it much easier to do is because opiate addiction and opiate overdose and opiate abuse and trafficking, for that matter, has become a problem in recent years, right?
It has.
The government asked you questions a lot about the opiates and what you prescribed her, and the amounts, and the times. You had the ability to see this screen that I'm scrolling up and down on. Now it has highlights, you didn't make that, right?
No.
They're highlighted for ease of reference. You see here that yellow is highlighted for oxycodone. And it says Masteller oxycodone, correct?
Uh-huh.
Now, this is such a small document, I've had to blow it up. So let me screen back up and say, what it depicts. Patient, patient's address, dates that things were sold. I think I have this published. I'm going to move to admit this as defendant's D.
I need more, I don't know who,
Then we should unpublish it.
I don't know any foundation about this document.
So you recognize what a Doppel printout looks like, or a Doppel screen?
Yeah, this looks like the old printouts from Doppel.
And so this is what you could see if you looked up on, with your ability as a licensed physician, if you looked up on the Doppel controlled substances screen.
Yeah, we access it from the medical record now.
You indicated that you would do that as a doctor in the course of your care, right?
Yeah.
And
Yeah.
Sorry to interrupt you.
Oh, yes, I would. It was hard sometimes to access it because of password issues
But
with
this
it.
is
But yeah, this is the Doppel.
what it looks like.
This is what it looks like, and I see lots of.
We're gonna get to what
ER
you see,
visits.
but we're laying some foundation. That was my fault. I didn't lay it. I showed it to the prosecutor, but I hadn't done it with you. So I now move to admit this as defendant's D.
Ms. Hunt?
No objection.
Thank you. Court will receive defendant's exhibit D. Wish to publish?
Yes, and I'm sorry that I didn't, that it got published a little prematurely. All right, where we were talking about along the top, we can, patient, these are all Casey Terry, right? As far as you can see as I've scrolled?
Yes, they are.
All right. Then we get the date of birth, that's not important, neither is the address. And then you can determine when you look at this, when prescriptions are written, right? Here at the top,
When the pharmacy fills them. Yep.
it says RX written, RX filled, right?
Yep.
Okay, so we get to know what the drug was, drug name, right? Quantity, here,
And days. Yep.
days is for what it's, if it's taken as per prescribed how many days.
Right, how many days it should last.
Should last. Thank you. Phones, we get to know what pharmacy it was. And some other numbers that have to do with DEA numbers and prescription numbers, right? That's what the kind of information I just showed to you and the jury you get to know from this topic. Now I'm going to go to Masteller oxycodone. As we tab up, this starts in terms of the date on May 30th. I'm sorry. When we get to these dates written and dates filled. Bottom of the dates written column is December 30th, 2022, right? Billed is August 2nd, 2023, do you agree?
Mm-hmm.
So we can run this all the way up to 8/5. This is roughly a week before she passed. What was written? It was filled on 8/7, less than a week before she passed away. That's the time range we have for what prescriptions were written to her, when they were filled, what they were for, what pharmacy she filled them at, etc. Go down here and give you the benefit of confirming that these yellow lines have to do with oxycodone, 160 counts.
Yep.
As we go up here, we have another 160, 425, 718. These are still the dates that are in 2023. Looks like pretty much every yellow line representing your oxycodone. Now, oxycodone, do you think that's different than Percocet?
No, it's the,
That's how it would look on the doc.
yeah,
Okay.
yeah.
Just wanted to clear it up because you'd said Percocet. Right up to a couple weeks before her death, another 180 here, right? Looks pretty clear that she had other oxycodone that she filled of a 40 count on 2 days later. The screen line that I'm on,
Yeah,
agree?
I would agree.
Looks like that's Jason Scott Erickson.
Don't know who that is.
No, you're her primary care physician, and you don't even know how she got a prescription from a Dr. Erickson that she filled for
I have no idea.
oxycodone.
A lot in those last couple weeks. Probably ER doctor, ERPA.
Okay? You don't know from your chart. From your chart, this is not something that in connection with your primary care, she is filling, and you can even see that she's filling, right?
No,
She's certainly not telling you, I've got other doctors I'm getting more and more pills from, right?
nope.
You wouldn't have given them to her if you did, right?
She would have broken the contract and she would have been disconnected immediately.
I mean, this is a sign of an opiate abuser, agreed?
Agreed.
She's doctor shopping, right?
Yeah, she is. So Epic is the nephrologist. That's the
Right.
kidney doc.
We've got Epic in there. Let's see, here's 7/23/24. This is right in that same week.
But is
40
this-
oxys.
This is pain management, maybe, or this is the orthopedic surgeon, because this is right about the time of her surgery.
Shelley Duncan.
This
Who's
is
that she got the 40 count and filled?
These are both between her two surgeries on her knee.
Yeah.
So this is the extra pain management that ortho had provided for the knee surgery and knee replacement, possibly?
7/23. Well, let's see. Again, if you knew that these sorts of numbers of opiates were being thrown at her, you wouldn't have given her the 180 that you prescribed to her on 7/29. Agreed?
After the knee replacement, she would have required more, right? And let me correct,
Well, let's go to this, let me ask the question. 7/1, July 1st, okay? Let's just start with that one with the 108. Then she gets 40 on the 23rd, and that could have been in connection with some knee surgery. By the way, you knew your understanding was she had 2 knee surgeries, right? You testified to that.
Yeah, my understanding was she had 2.
She told you that.
I knew she had the replacement.
She told you she had 2.
Yeah,
You aware now that she only
I'm
had
suspecting she only had 1.
1? Get pain medications when you get knee surgery, right? Right?
Yeah,
This has been admitted, it's, we'll have to get it in a form that can be reviewed by the jury in terms of these numbers that you have seen and can agree that the green lines for oxycodone other are not you and are replete, especially in the last month of her life. Agreed?
agreed.
We can take down the pub sheet. Now, she had this knee surgery, totally, let's just talk about the one that was real. Towards the end of her life,
Right,
in July.
7/25.
And again, as you stated, clearly, could it result in additional pain medication, right? In terms of her attention to you, you talked about the fact that she would text you on your actual phone number, right?
Yeah,
Do you remember when she got that?
I have no idea.
You said she started sending you texts. Let me ask you this way. The attention seeking that she was trying to get from you really started ramping up in the couple months towards the end of her life, agreed?
It's been a long time. I don't remember on the text messages. I don't have them. If you have them, I'm sure you do.
Well, I got 70 of them. Do you think that sounds like the sort of attention she was seeking from you?
She was a high attention seeker.
They were long, weren't they?
Some of them.
Did you respond to them?
We've had the nurse call her and tell her to follow up.
You didn't. I mean, it's not your job to respond to constant texting from a patient who somehow got your number, right?
I may have said, I don't remember. I may have responded to some of them. Go to the ER, I don't know. I'm sure I did if you're bringing them up.
Just briefly talk about DNRs. There's a lot of legal aspects to do not resuscitate, right?
Right.
And a doctor wants to know if their patient has, for that matter, directives and things like that, right?
Right,
And you enter into them with your physician, your treating physician.
right.
And you might enter into them with, Epic may have discussed an advance directive with her, right?
Could have. Epic, the orthopedic surgeon, ER doc,
Nephrologist,
anybody.
these are anybody who's treating her, right?
Right,
Okay. These aren't just things that otherwise are, as you understand them, as you use them, they're patient doctor, they're patient provider documents, agreed?
right,
All right.
yes.
I mean, if I
For
told
DNR.
you that I have a DNR, you could choose to believe me or not. If I said I had a DNR with somebody, right?
You would believe it if you showed me.
Well, or you thought I was someone that you could believe. If I was your best friend, you're still gonna demand that I go find it, go find the doctor, find the signature, go show you a copy if I'm your best friend?
No,
Very
but
nice.
I
Okay, so these are
Or CPR.
documents that certainly you have in the legal practice. And as you mentioned, sometimes you can manage these things without a doctor. You know that you can go online and get an advance directive put together?
yes,
That doesn't have to be a doctor, and doesn't even actually have to be a lawyer, does it?
no,
But there's one thing that's certain that you understand, and that you can agree with me as common understanding, that DNR means do not resuscitate, right?
Right.
If someone told you they had a DNR, you would take that to mean they were telling you they did not want to be resuscitated.
Right.
Let's talk about insulin for a sec. It is hard to predict the pharmacokinetics of anything, really.
Of anything.
I mean, pharmacokinetics, tell the jury what that means. I use the word, but you're the doctor.
Pharmacokinetics are how fast a body metabolizes a drug. How
Yeah.
fast the drug acts, when the first action starts, its peak effect, and when the drug is out of your system.
So the features of what the drug's doing in you,
Right.
and the pharmacokinetics of insulin are hard to predict too, right?
There's a range.
And there's all sorts of kinds of insulin.
There's a predictable range, and we can go through all those types of insulin.
But I mean, there are lots of kinds. I'm just asking.
There are. There's short-acting, intermediate-acting, and long-acting insulins. Typically, we break them in, and within those, there are slight different pharmacokinetics of the different brand names of those insulins. They're designed a little bit differently, yes.
Right. So in this particular case, you actually were shown, not just 1 minute here. You met with the police a couple times in relation to this case, right?
Uh-huh.
Gave a couple interviews to Detective Barney and Special Agent Richard Hales was there, right?
They came into the office, yes.
Did you know those were recorded?
No.
Then, would that have been okay with you for them to come in and
Fine.
talk to you about your patient with
Yeah.
recording without your knowledge? At any rate, then you have offered, you've talked to the prosecutors about your role in this case, right?
Right.
You've been given information about the case, right?
Some.
Don't you remember the detectives talking to you about some of the things that had happened with the case and the things they had learned? Like that Doppler chart showed?
Yeah, they had uncovered quite a bit with opioids, Casey and opioids.
And frankly, also learned how she was getting benzodiazepines even though no doctor was prescribing her to her, right?
Right. Yeah,
Connected to this, trading drugs for drugs, right?
basically.
In connection with the case as well, the prosecution, and I don't know if the police did this, to be honest, because I don't know before the one hearing that you did previously testified, this had been done with the police or the prosecution, but you had been shown evidence related to the case that was purportedly taken off a glucometer that read Casey's blood through the day on August 12th, 2024, right?
And I reviewed that data again today.
You did? And
I did.
we didn't hear any testimony about it. The actual chart that relates that data, I don't think we have had addressed. And I'm sorry,
Scott, you're still publishing.
I don't mean to be publishing, I'm not publishing.
Not to the jury.
Can you see freestyle blood glucose monitor Casey Terry
Uh-huh, I can.
on your screen? Does that look like the chart that we're discussing,
Yes.
that you reviewed?
Uh-huh,
So your understanding, and you've reviewed it before, right?
right.
So your understanding that it was created off of a glucometer that purports to be readings from Casey Terry, right?
Right.
relation to the role that you played in this case and the things that you've been asked to do, were you shown medical records from her hospitalization on the 12th?
I reviewed all the medical records through the hospitalization.
And you've given consultation to the state with regard to insulin overdose event that these numbers are related to that happened on the 12th, is that right?
Say that again?
You knew that these numbers relate to an insulin overdose event that the
Right.
state reports and to have occurred, right?
Right,
And that the police were investigating,
right,
that are material to this case charged against Meggan
Right.
Sundwall.
yes.
When you look at that chart and consulted with them, having known all of the medical records and knowing her, you agreed that as far as what you know in medicine and your personal care of Casey Terry, that the information was such that you could not opine that Casey Terry had exogenous insulin introduced to her after a point where she would have been unconscious. Agreed?
Say that again?
Let's put it up. May I publish? I can mark it. It hasn't been offered by the state yet, and I expected it would have had been. Or we can use it as illustrative at this point. Does the state have a preference?
We're going to 10. It's number 10.
We plan to introduce it as State's Exhibit 10. I guess at this point you can use it as demonstrative if I don't have an objection to that.
Thank you.
Okay
And
to
if we
publish,
can
okay to publish, Ms. Hunt?
Yes.
All right, here's these numbers, here's this chart. Sorry, we've been sort of talking ethereally about this, and you've worked with the prosecution in interpreting these numbers from your perspective with your experience and as Casey's doctor, right?
Right.
So this were blood glucose readings. Let me get right to it. As you go down these times that are on the far right, they're the actual time in Utah at the time that the readings were taken. You've been shown these and asked what these blood glucose levels might mean to you as a doctor, correct?
I have.
Let's look at the one from 1343 and go left to where it says 43 is a glucose level, right?
Yes.
Now, I think you've opined, let me ask again today, Casey could have been conscious, right?
She could have been.
30. At 2 o'clock in the afternoon, I think you have opined before that you don't think she would have been conscious.
I don't think so.
And thereafter, with these numbers,
Definitely.
you don't think she would have been conscious, right?
No.
So let's talk about 2 o'clock in the afternoon on the 12th. With all the information you have in terms of the timing question, with the medical records, your expertise, you couldn't determine with the degree of medical certainty that anything was introduced exogenously into her after 2 o'clock. Agreed?
No.
And no, you do agree, right? Sorry. You said no. Nothing was introduced, right?
Nothing was introduced.
And going forward up to 918.
We don't. I mean,
You don't know.
we don't know.
So with all of the medicine you saw, the records from the hospital, the history you had for 4 years with her, you can't say that anything was given to her after she would have been unconscious, right? That's what you mean. Just don't know.
No. There's no way to know.
And as a matter of fact, you can't know whether she actually took something before she took this reading at 9:18 in the morning, right? She
There's-
should have taken something before then that caused these readings. The way insulin works?
Possibly.
Okay.
So your short-acting insulin is going to be about 20 to 30
I've got
minutes.
the answer. You
Okay.
want to explain it, she could have. I don't have any,
Long-acting would have been consistent with this, basal insulin.
I should let you explain it, I guess. You've explained why, we don't know, and it's possible that prior to 9/18 on the 12th, it is when exogenous insulin was ingested that could have caused the numbers on this chart to do what they did, right?
Right,
I cut you off, and I apologize for that.
that's okay.
I'm looking at the clock and getting nervous.
Nope.
I know the times that apply, and I'm finished. Thank you for answering my questions.
Redirect.
I'll try to be brief. You were shown, sorry, Scott, did you end up admitting the Doppel as an exhibit?
Yes, D, I believe.
You were shown, I don't have it, so I'm not able to pull it up, but the Doppel records
Right.
defense exhibit D. It had a bunch of highlighted, it went from, I think, 2022 all the way up to shortly before her death in 2024. Does that sound fair?
Yes,
You talked about the increase toward the end that were not, that were oxycodone that you had not prescribed, were around her knee surgery. Is that right?
right.
You may have believed that she had 2 knee surgeries, but the knee replacement, is that one that you have verified happened?
Yeah, I hadn't seen her after, and so yes, I thought there was I read the note in the chart yesterday, and I thought there was a knee surgery that happened. I didn't see documentation from the orthopedic surgeon on the first one.
The second one, though,
Second one was done at Mountain Point Hospital.
and you have verified that independently?
Yes,
And that's the one that happened in late
the knee
July?
replacement, July 25th.
July 25th of 2024. So you would expect maybe additional, I think you said extra pain management for knee replacement might be something that you would expect to see.
That's what the orthopedic, yes, typically they're gonna have extra pain management on top of what they're already getting.
You mentioned that Doppel, your ability to check patients' Doppel records and what meds they're receiving has changed over time. It used to be more difficult.
Yeah, they used to, password requirements were very difficult, it was very time consuming. We had to frequently call Doppel, couldn't get a hold of anybody. It was very difficult with Doppel to work with. Now they've actually added a link into the electronic medical record that at every visit, we can just click on the link and review all their medications very rapidly, and who's refilled them and the dates that they've refilled them.
When did that change happen?
A year and a half ago?
Let me ask this and let me see if you remember what you were going to say. Mr. Williams asked you a question, I believe about the Doppel records, and you said something about, let me correct, and I believe you were making reference to some of your own charting that he had given you. Do you remember what you intended to correct?
Yeah, so I had, and again, dosing and this came from the note, she was initially on 15 milligrams of oxycodone at the same frequency. So her initial doses were quite a bit higher when she came to me. At least that's what I had written. Would have to go back into Doppel and look at that.
Okay, so on direct testimony, I believe you said 10 milligrams, they're actually...
That's what I was prescribing.
Okay, and she came to you on 15?
That's what my note says.
Okay.
So it says she was on 15 Q 4 to 6 hours, which means 1 tablet every 4 to 6 hours.
Okay, and is your testimony from direct still true that you did not give her a prescription that was higher than that? You lowered her at some point, and then when she complained of more pain, you may have gone back up to that level, but you never raised the level that she initially presented with.
I never went up to the level she initially presented with.
And she didn't, in fact, she didn't even seek to ask you for a higher level.
She never asked.
Mr. Williams asked you about whether you might, if he was your best friend, believe if he told you he had a DNR. You remember that question?
Uh-huh.
Sorry, let me try to fashion this question in a way that makes sense. As a doctor, if somebody's your best friend and they tell you they have a DNR, would you believe it if you were being required to medically act upon it or being asked or able to medically act upon some kind of medical emergency? Would you just say, he's my best friend, he told me I had a DNR, there's nothing I can do here?
Probably not.
And why not?
I don't know, because there's no verification of the DNR. That's,
Why is it important to
yeah, I don't know on that one. I don't know what the situation, I would probably believe him.
Okay,
On a friend, a close friend,
on a close friend, you would believe them.
yeah.
Why, you said before that verification is important. Why is that important?
Well, we have to know what their wishes are. I mean, it's a signed order. A DNR is a signed order. It's like a medication administration in a hospital. It's like it is a signed order by a physician.
If somebody is your best friend, but they've been telling you obvious lies for years about many other medical information, would you believe them about the DNR then?
No.
You've been shown the chart that the state intends to admit as Exhibit 12. That's the glucometer readings that we just were looking at of Casey on August 12th.
Uh-huh.
You're not, what's an endocrinologist?
Diabetic doc, specifically, a hypoglycemia diabetic in this case.
You're not an endocrinologist?
Sugar. I'm not an endocrinologist, no.
You were, sorry, I'll be really quick. In the charts from 2020 and 2023 that Mr. Williams gave you, where Casey is giving you readings of from her glucometer,
No.
You said that those are in the past, and that she may have given you a collection of them all at one time.
She may have.
When you look at the 2020 one, and sorry, I don't have it available, so I can't put it up. Before the readings begin, there, I believe there's a paragraph, and she says, here are the blood sugars you asked me to send you. Do you see that?
Uh-huh.
And then at the end of the list of sugars, I think the last one, she says something like, this morning, this was my reading. Do you see that?
Yeah, I was 74. Uh-huh. On the 26th.
Does that help indicate to you whether they were sent daily and whether you were following up daily, or whether you had asked her to, check it for a week or however many are there and send me the collection of them when you're done?
Usually I'll have a monitor for a couple of weeks.
If she was in the clinic and you were actually getting some of these numbers on a monitor that you were observing and you were doing the testing, would you have taken different action?
Yeah, I mean, if we test her sugar right then, and there may have been a point of care glucose that we did at this time, but I don't know, I don't remember. But anyway, yeah, we would either give her a glucagon injection or we'd give her a glucose tablet.
And you said even after getting this
And
list of-
monitor closely.
Okay. You said even after getting this list of numbers that seemingly are fake or made up, that you still tried to verify, you still did testing, you still tried to follow up with, what might be the cause of numbers like this, and are these consistent with the
Yeah, we did
Casey's
pretty
condition.
extensive blood testing and referrals to endocrinology.
Ms. Hunt, we're past time.
Okay, that's all I have. Thank you.
Thank you. Can this witness step down?
No objection to releasing the witness, Your Honor.
Yes.
Thanks for being here,
Thank you,
Doctor.
Your Honor.